Thank you, Mr. Chairman. Dear colleagues, the topic is, as I said, monitoring treatment in real or pseudo-progression, and I will actually add a few words about radiation injury at the end. I have no conflicts of interest in part of this presentation, even though I do admit I am very interested in monitoring treatment and in brain tumors. The layout would be that I will give you a couple of words about the conventional MR imaging in progressing as versus pseudo-progression, the classic criteria, size and tumor enhancement, but also the limitations. And then I will talk a little bit about the advanced techniques that we have, and here I would like to combine both the diffusion and the perfusion, because when we're talking about monitoring treatment, I think both of these modalities are important and should be used combined. And also, finally, a little bit about the new and advanced imaging techniques in terms of treatment response using so-called parametric response maps that was mentioned by the Chairman Lucic previously, to show you that you could actually use this not only for characterizing overall survival or time to progression, but actually also separating pseudo-progression from true progression. So, what is the therapeutic effects, the changes we could see in a patient that had been treated for a brain tumor? Well, we could have true progression, of course, and we can have what we call the pseudo-progression. And depending on if you're using certain kind of treatments, such as antigenic treatment, like Avastin, you might actually see pseudo-response. And then later in the treatment interval following a patient, there are some patients that will develop radiation injuries or radiation necrosis as damage to the therapeutic they have gone through. When we are trying to define if a patient has responding to a treatment, we used to use what we call the Macdonald criteria, using measurement of the size and the enhancement of the tumor over time. And also there we have shown now that diffusion and perfusion might actually be a better measure than just using size and contrast enhancement. Here is just an example given to me by Professor Jäger. I have a couple of his slides because they're so good, it's stupid to try to do your own. Here is one showing in the first row the baseline of a tumor, and then you can see 10 months into therapy that now we have pathological contrast enhancement at the area where the previous tumor was, and 16 months after therapy, there's this obvious contrast enhancement growing, indicating that this tumor is now progressing significantly. Another way to look at it, as is the classical pattern, again, is just to do measurement. In orthogonal, the area that shows the most enhancement or the most, in this case, it's a T2, so you will see the signal abnormality in terms of the T2 signal effect and not only the tumor. So what is the limitations that we have with the Macdonald criteria and actually resulted in some changes in 2010? Well, first of all, there is shown to be a substantial intra-reader disagreement between different readers, both when it comes to read CTs as well as MRs, when you try to use this criteria of size and contrast enhancement. Secondly, which is maybe more important, is the fact that there is no assessment of the non-contrast enhancing area at that time, and that only contrast enhancement was used as a surrogate marker for progression of tumor, which is not the truth. So therefore, 2010, there came this new revised criteria, and the most important parts in that is that now we are including non-enhancing parts of the tumor as part of disease progression. And we should not only look at the tumor enhancement, but the surrounding T2 or flare signal abnormalities that we can see. Also, due to the fact of pseudo-progression that has been up in the air for the past almost 10 years now, we know that we now exclude all patients from any form of clinical trial the first 3 months after therapy, just to make sure that we do not include patients that has a pseudo-progression and not a true progression. So, Looking into their way of looking into the criteria for progression, so in the first 12 weeks after chemotherapy, if you see non-contrast enhancing areas outside the radiation field, you should be concerned for progression. After 12 weeks of chemotherapy, you should see if you have a more than 25% enhancing of the area indicates tumor progression, or if you have new enhancement areas outside the area of of the radiation field. And also if you see significant increase in the non-enhancing parts in terms of T2 and flare signal abnormalities. And if the patient then deteriorate despite corticosteroid treatment. So, while saying all this, now we could wonder, do we really have a need for advanced imaging and monitoring brain tumors? And if so, which kind of techniques are we going to choose, and do they actually work? So I will give you a description of the perfusion, diffusion, and a few words about spectroscopy, where I think could be helpful to evaluate especially then true progression from pseudo-progression. Here's an example of a 21-year-old male who presents with a lesion in the posterior fossa 24 months after previous radiation therapy. And you can see this enhancing lesion here. Now, looking with the perfusion-weighted images, we can now see that there is an area of increased cerebral blood volume, cerebral blood flow, and there was a decrease in the MTT, indicating that this was certainly a recurrent tumor and it's not pseudo-progression or radiation necrosis. Here's another example of a 54-year-old male. He's 6 months after radiation therapy and chemotherapy with Temodar. He presents with this lesion here with new pathological contrast enhancement in the vicinity of the resection site, or the resection here. And if you look at the perfusion area, you could see, yes, there are some areas here presenting with increased cerebral blood volume and cerebral blood flows, where there are other areas where you don't see any increase in the perfusion, indicating that these are a patient that, yes, he has focal areas of tumor progression, and he most likely also have areas what we will think in this case to be more radiation injury related. Another case given to me by Professor Law from in Los Angeles, again on a patient that had been treated GBM. You can see he has this in January, has an area of signal abnormality in the temporal lobe on the left with a little bit of enhancement. 4 months later, this enhancement has significantly increased. Now, is this tumor progression? Is it true progression, or could it even be radiation injury? Looking at the perfusion data, we could see that, yes, of course, there is a significant increase in the cerebral blood volume and blood flow in the region of pathological contrast enhancement, as well as an elevated of the choline peak, indicators both of being a true progression and not pseudo-progression. Another case here given to me by Dr. John from Henry Ford in Detroit, a patient who in January had this lesion with a little bit of flare signal abnormality. There is not much of any contrast enhancement, maybe a faint enhancement here, but more or less none. And if you're looking at the cerebral blood volume, the values was 1.4, that looked fine. Then 4 months later, we see increase in the flare signal abnormality. So we are now talking about not the tumor, but the surrounding area. And not even any more pathological contrast enhancement, but a significant increase in the cerebral blood volume, indicating again that this is true tumor progression. So what is then pseudo-progression? Well, it is changes that we can see usually 1 to 3 months, sometimes a little bit longer, after radiation and chemotherapy. Usually it's considered to be radiation-induced changes in the vessels that leads to transition increase in the enhancement. And there has these clinical implications that I mentioned before, that now we do not want to put any patient into any kind of clinical trial for changing of therapy the first 3 months, just so we don't include patients that has a pseudo-progression and not a true progression. So what we will see in pseudo-progression is that you would have this consistent increase in size and number of contrast-enhancing lesions 2 to 3 months into chemotherapy. And it's usually when you combine radiation with Temodar, and it occurs in up to 30% of the GBM patients. Also, you will find it's more frequently seen in patients that has methylation to MGMT. It's most likely an inflammatory reaction with increased permeability of the blood-brain barrier, and usually if you leave this alone, they will decrease. If you decide to do a surgical resection, you will find that the histopathology will most often indicate that it's radially-induced necrosis and no true tumor cells. Here is just an example of one of these patients from my own cohort, where we had pre-treatment. This patient has been treated and then he goes under treatment for 1 month, and now we see this area here of enhancement, ring and form enhancement, a little bit irregular in shape, not very uniform. And this patient was just followed, and it was actually disappeared again, and this was just a case of pseudo-progression. Here is another example of a pseudo-progression. Again, pre-treatment, there is a little bit of enhancement before the patient goes for chemotherapy and radiation. 1 month into the post-radiation, we have now a larger area of pathological contrast enhancement at the site. And just leaving this patient alone, no change in therapy, these lesions slowly disappeared, and there was another case of pseudo-progression. You could follow here is a case given to me by Marco Essig, now in Winnipeg in Canada, that is from the literature. You could see pre-treatment, post-treatment, the patient post-surgery had been a resection, and then 3 months into therapy, this large pathologically enhancing with areas of necrosis or cysts in this region, and then 5 months following therapy with no change, you could see a faint, that the contrast enhancement is fading away, another case of pseudo-progression. Also in this case, again, pre-treatment, then two cycles of Temodar, 1 month into the therapy, you could see post-therapy, you have this increase in the size of the lesion. And then by just leaving it alone, continue with the treatment, 6 cycles down, the lesion has completely disappeared. It was, again, a case of pseudo-progression. And finally, here is a case by Professor Jäger. You could see on the baseline, you have a ring-enhancing lesion with a surrounding edema. 8 weeks into therapy, we now see more pathological contrast enhancement, especially in the medial side of the lesion, and you have a significant increase in the flare signal abnormality with a little bit of compression of the ventricle. 16 weeks into therapy, there's still some enhancement, but we can now see that the flare signal abnormality is significantly decreasing, and 6 months after therapy, almost all the contrast enhancement is gone, and the flare signal abnormality has also significantly diminished. Another case of what we call pseudo-progression. Now, can we then use, again, perfusion and diffusion or spectroscopy to help us to separate the pseudo-progression? Here is one case where you could see the contrast enhancement. You could see when you're looking with perfusion data, what you get is a decrease in the cerebral blood volume compared to true progression where you would have an increase in the cerebral blood volume. You will see an increase in the choline peak, but that is mainly just due to changes in the myelinization, where there's a breakdown of some of the cells. And you have also an increase in the K-trans. But in pseudo-progression, you would have a decrease of the cerebral blood volume in the region compared to a true progression, where you will see an increase in the cerebral blood volume in the progressing tumor. Here's an example of a patient that we had that was treated. You could see the contrast-enhancing lesion. He goes on and loses flare signal abnormality in May, and then 6 months later, you could see there has been a shrinkage of this lesion. And then a couple of months later, we now see a new focal area of pathological enhancement, and we could also see more signal abnormalities on the flare, indicating radiation effects, or could it be a true progression of the tumor, or is this a pseudo-progression, or maybe even radiation necrosis? Well, doing the perfusion measurements, again, an increase in the cerebral blood volume and an increase in the cerebral blood flow, as well as the K-trans, and here again, also adding the diffusion-weighted images, where we now see, back in January, there was no restricted diffusion in this area. 4 months later, there is a focal area of restricted diffusion indicating increased cellularity, higher cellularity, as well as increase in the perfusion, this is certainly a recurrent tumor. This is not neither radiation injury nor pseudoprogression. Another example of a lesion in the cerebellum with a pathological contrast-enhancing lesion, the first follow-up after MR, you could see like this. This is a follow. We looked with the perfusion images. This was the initial lesion with a contrast enhancement, with an increased cerebral blood volume. But then you could see on the following images there is no increase in the cerebral blood flow or blood volume, despite there is a pathological contrast enhancement. And this was just a case of pseudoprogression in the posterior fossa. So this was pseudo-progression and true progression, and I cannot help to add a few words about radiation necrosis, because sometimes radiation necrosis could occur quite early in treatment, so there is a window where you could talk about pseudo-progression versus radiation necrosis as well. So you cannot forget that completely. And it occurs in up to 25% of patients that are treated with conventional therapy for brain tumors. And as you see, they could come very early, already 2 months into therapy. And it involves the 3 different types of cells, both the neurons, the glia cells, as well as the vessels. And what one thinks is that it's an effect of the fibrolytic enzyme, and immune mechanisms might be involved. And there's an injury to the vasculature with changes in the capillary permeability, resulting in edema in the acute phase, and then you will have more vascular endothelial damage in the more chronic phase. The signal abnormalities that you could see in patients with radiation injury is quite diffuse. You could have anything from contrast enhancement increase to conversion from non-contrast enhancement to contrast enhancing areas. You could have even contrast enhancement at local focal areas rather distant from where the initial tumor was. And so the morphological features could be very misleading, and therefore it's very important when you deal with any kind of monitoring of patients with brain tumors that you actually have clear information about the primary tumor, when it was operated, when it was treated, and with what kind of chemotherapy and what kind of radiation and how much, and the time between treatment and when you actually do your scanning. Here is just an example of all biopsy-proven cases of radiation necrosis or radiation injury, and as you can see, they could be quite misleading and could certainly look like both tumor progression or even pseudo-response in some cases. So the radiation necrosis would, as well as pseudo-progression, would show you low CBV. So high CBV in a true tumor, low CBV in pseudoprogression, and low CBV in radiation necrosis. And you could also see that the slope, if you have a recurrent tumor, you would have a much steeper slope of the perfusion compared to when you have radiation necrosis, where you would have a much slower slope going up. Here's just an example, again given to me by Professor Law, where you have one lesion here in the parietal lobe on the left with the contrast enhancement, another lesion here with the pathological contrast enhancement in the frontotemporal lobe. And if we're looking at the perfusion data, the first case is radiation necrosis, and you could see that in terms of the slow slope going up, as well as the decrease or low cerebral blood volume compared to the increased cerebral blood volume in the patient with a recurrent tumor, and a much steeper curve. So when we're monitoring patients, we want to know, can we now predict the response in the treatment we are giving the patients? And we know by using MR spectroscopy that both the presence of increase in choline to creatinine as well as increase in choline to NIA as ratios are predictors of poor survival. And also lactate to NIA have shown to be a good predictor for the time we could expect the patient to survive. So if you have if you have lactate to NIA that is more than 2, then there's 20% survival for 12 months. But if you have a lactate to NIA that is less than 2, the oversurvival rate is longer. Also, when we're looking at diffusion-weighted images as well as perfusion, they can predict the treatment response, as was mentioned earlier by the two speakers. So if you have treatment-responding lesions, you will see an increase in the ADC values, whereas in non-responding tumors or lesions, you will see a decrease in the ADC from baseline. And also perfusion, as I have shown you previously, have shown now to be a very good predictor for actually endpoint evaluation. And here is a very nice scheme. It's a paper written by Imagenologia together with Rolf Jäger and his group from London, where they showed and demonstrated the value of perfusion and the measurement that you have. So if you have a low-grade tumor with a cerebral blood volume of less than 1.75, you had a very long survival. But that was the same for high-grade tumors with the same low cerebral blood volume at baseline, compared to low-grade tumors or high-grade tumors that had higher values. So depending on the cerebral blood volume value at baseline, you have the possibility to predict the overall survival and time to progression. And it doesn't necessarily only has to do with high or low grade of the tumor itself. So finally, a few words about the so-called parametric response maps, which is a technique where you use voxel by voxel changes from baseline to the next 3-week or 1-week interval to see how they change voxel by voxel within a lesion. Gives you the possibility not only to study the whole lesion itself, how it changes, but actually focal areas within the lesion, and that has shown to be a useful parameter, a method for predicting outcome, but also maybe to talk to clinicians which area of the tumor might be actually be needed more treatment, which area of the tumor might actually be responding. So using these maps, and it was actually something that was started back in University of Michigan, Ann Arbor, with Brad Muffet, who published the first paper back in mid-2005. Using these changes in the relative changes in the volume, voxel by voxel, you're able to both use cerebral blood volume as well as the ADC as markers. So if you, for example, in ADC, if there was significant change in the ADC between two studies, then the tumor was responding. If there was no change between the two studies, there was no response region. And by doing these scatter plots and giving them different colors, we could see which ones are increasing, which are stable, and which ones were decreasing. And that have resulted in a couple of papers where we have been looking at the overall or predicting of overall survival and or predicting time for progression. So looking here at the parametric response map with a cerebral blood volume at week 3, depending on the cerebral blood volume changes, now we're talking changes in values, not numbers. The one that had the less changes, that had a better survival compared to those that had a higher changes in cerebral blood volume, whereas those that had a higher changes in ADC had a better survival than those that had a lower changes in ADC numbers, voxel by voxel. And that was at 3-week, and then we compared the outcome 10 weeks, the same patients, and we could see that the patient that had a stable disease or partial response compared to those that were progressing, and the green and the blue are the same patients. So you could see that by using the cerebral blood volume parametric response maps or the ADC parametric response maps, already 3 weeks into therapy, we could tell which of the patients would have a longer survival compared to the other, and which one would do poorly. And it fitted very well with the radiological outcome 10 weeks into therapy. Now, these have also been implemented on pseudo-progressions versus progressive disease, where we have been able to demonstrate again that if by using this technique, you are capable of separating patients that have pseudo-progressions from those patients that have a true progression, both by looking at pre-treatment and then 3 weeks into therapy, and you could see that the histograms for those patients that had pseudo-progression are distinctly different from those that have a true progression disease. And when you do the statistics, we can see by using the cerebral blood flow in this case, you can get a significant difference, a statistical difference between patients with stable disease or partial regression compared to those with progressive disease and those with pseudo-progression. So there's distinct differences between the way the values for the cerebral blood flow was on the parametric response maps. So that might be a useful marker as well. So using this technique in the future, diffusion and perfusion metrics in parametric response maps might be a valuable tool, and we might then define already 3 weeks into therapy if we're going to continue with the treatment or if we're going to change the treatment based on what we see 3 weeks into therapy instead of waiting 10 weeks as we do now. Finally, then, a few words about the consequences of ADC and for prognostic markers when we are talking about angiogenic therapy like Avastin. And again, here we show that ADC, pre-treatment ADC histograms are very good in stratifying the progression-free interval in patients treated with Avastin, and the ones that had a higher ADC value had a longer overall survival, or progression-free interval, I would say. The same goes using when you look at those patients that had a steady decrease in the mean ADC in the contrast-enhancing lesions as well as in the non-contrast-enhancing lesions, where the progressive patients had a steady decrease, while those patients that had no progression of disease, the ADC values did not change. And lately there was a paper published in AGNR by Dr. Mong, where he also demonstrated that the patient, because when we're talking about antigenic therapy, we had a problem with pseudo-response and also the diffusion abnormalities that we could see very early on. And those patients that actually presented with diffusion abnormalities in form of restricted diffusion demonstrated also a longer time to progression-free interval. 3 words about the future imaging techniques that I'm working with my group in Lund at the moment. One of them is the diffusion kurtosis imaging that you all have heard about previously with mean kurtosis, that gives you a degree of free water diffusion and the deviation from the free water diffusion and might reflect the complexity of cellular organization. Another method is the apparent exchange rate. It's a permeability imaging where we try to relate to the cell membrane's permeability, and that might play a role in characterizing cellular function. And lately now cell shape imaging, where we, by using diffusion tensor imaging and then do a special kind of encoding, are capable of coming up with what we call the microanisotropic value, FA. And that holds very promises into better characterize the microstructure of a tumor, which could have a prognostic value as well as treatment importance. Here, just an example of AXR, where you could see the permeability, the FA, and then the composite, and you could then, we color code this, and we could see the different permeabilities, intra and extracellular water component. This is a very novel, and we have not done many patients yet, or not non-patients yet, just normal controls. But here's an example of how you can use the micro-FA in a patient with a meningioma, where FA here almost looks very darkly the same, but if you look at the micro-FA, you could see that there's a different FA values within this lesion that would better describe the microstructure of the tumor itself. So for meningioma, maybe not so interesting, but certainly more interesting for other more malignant tumor in the future. So in conclusion, it's a take-home message. Pseudo-progression and pseudo-response, if you treat with antigenic therapy, as well as radiation necrosis, consist to be diagnostic challenges for us. Pseudo-progression usually occur early in the treatment, within the first 3 months of treatment, and it will be demonstrated by increased contrast enhancement of the lesion, and maybe also increase in the surrounding signal abnormalities on FLAIR and T2. Radiation necrosis usually occur later, after 6 months, but can occur already 2 months into therapy. And you could also see patients with radiation necrosis several years after treatment. And pseudo-response is something that is related to patients treated with antigenic therapy such as Avastin. And new biomarkers from perfusion and diffusion weighted images and parametric response maps, as well as some new biomarkers that might be in the horizon, will certainly, in the future, even better improve our capability of monitoring and predict outcome for patients with brain tumors. Thank you very much for your attention.